Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. It's my great pleasure to welcome Dr. Tim Murray to talk on Ocular Oncology Update 2021, what every optometrist needs to know. Dr. Murray is currently the founding director and CEO of Ocular Oncology and Retina of Miami, Florida. His early academic career focused on development of an integrated ocular oncology service at Bascom Palmer Eye Institute, Sylvester Comprehensive Cancer Center, and in 2012, he founded the Ocular Oncology and Retina Center in Miami. He continues to be as a tenured professor in ophthalmology and radiation oncology with the Bascom Palmer Eye Institute and the Sylvester Comprehensive Cancer Center. Dr. Murray is a graduate of Johns Hopkins School of Medicine. He completed his residency and chief residency at the University of California, San Francisco in ophthalmology, and completed both a surgical and a research fellowship in vitreoretinal surgery and ocular oncology at their Eye Institute at the Medical College, Wisconsin. I can say, having known Tim Murray for several years and working with him and knowing of him before that, when I was in South Florida, I always like to do this as part of my introduction. Whenever we optometrists or ophthalmologists had challenging cases, difficult cases, corneal issues, neuro-op conditions, the really, really tough cases, they'd always say, send to Bascom Palmer, because Bascom Palmer is year after year ranked one of the highest, if not the highest, eye hospital in the country. However, whenever anybody had a suspicion of a tumor, nobody ever said, send him to Bascom Palmer. It was always, send him to Tim Murray. Tim Murray actually superseded and was bigger, in my opinion, than all of Bascom Palmer. Because when we thought tumor, we thought Tim Murray, he's a person. So with that, please welcome virtually, a nice virtual round of applause for Dr. Tim Murray as he talks about his specialty, ocular oncology. Tim, take it away.
Joe, thank you so much for inviting me to speak. You know that I love talking about this topic. I'm really passionate about it. I wouldn't say I'm bigger than Bascom Palmer, but I think when you refer, one of the take-home messages for me is you always try to refer to a person and not to an institution. And really, you want the best person wherever they may be.
But you really did, Tim, trust me, when we talked, you always transcended the institution.
I love that. Very, very sweet. So 20 years at Bascom Palmer, 10 years in private practice. I've got to see sort of both ends of the spectrum. It's a fascinating opportunity. I have really no relevant disclosures. I will be talking about innovative care, and we in oncology have no on-label treatments. So everything that I discuss with you is going to be an off-label drug or device. I sit on the FDA DODAC panel for ophthalmology. We're going to talk a little bit about a lot of things. And what I wanted to hit on was what I think really are the controversies. So you guys and ladies you're the front line. So one of the things to appreciate is that nobody walks in saying they have an ocular oncology problem. They come in with nonspecific symptoms, and you guys are the ones that see them and establish the concern and then the referral. So we're going to focus a little bit on the trending changes in the diagnosis and treatment of small uveal melanoma, the management of high-risk melanoma for presumed micrometastatic disease. That's really a new focus, and the application of proteomics and microarray analysis, genomics in the evaluation of tumors for tumor prognostication and classification.
Tim, I think what we're going to do is we might want to just start a polling question. Is that okay?
Perfect. I love it.
Let's do that right now. Let's launch our polling question. The two most common primary intraocular malignancies are uveal melanoma and choroidal metastasis, retinoblastoma and choroidal metastasis and hemangioblastoma, or retinoblastoma and uveal melanoma. We'll give everybody a chance. This will be a thinker question here. And while people are weighing in, I would say that when I was at Nova University and in our residency program, my residents would rotate periodically with Dr. Murray, with Tim. And after one day, they would come back having seen more melanomas than most optometrists will see in their entire career. And Tim, correct me if I'm wrong, you had 4 surgical melanoma cases today. Is that not right?
Yeah, so I'm still in scrubs and I look a little disheveled because I came right from the OR. But yeah, we had a big day in the OR today. We had 4 melanomas, and then I had to operate on a young lady with a VHL tumor on her optic nerve. So some exciting surgery. And yes, having the residents join us is always exciting.
And there are results to the poll. Good response. The number 1 response was uveal melanoma and choroidal metastases. So Tim, take it away.
So remember that the most common primary intraocular tumors are malignant melanoma in adults and retinoblastoma in children. But the most common intraocular malignancy is a metastatic lesion to the eye, typically to the choroid or the uveal tract. And we're seeing more and more of those cases, and they can often be subtle when they present. And we'll chat a little bit about that as we go forward. When I started, there was a concern that iodine 125, the radiation patches that you put on the eye, would not work for tumors next to the optic nerve, or would not work for very large or very small tumors. So we're going to address that. We understand, like with every oncology process that utilizes radiotherapy, if you don't get the treatment to the right spot in the tumor, the treatment is ineffective. And that comes into discussing localization techniques and what the expected success rates for therapy should be. And then really, I've had a big interest since I joined Bascom Palmer to move us away from enucleation. I think that there are eyes that have to be enucleated, but the real focus for us is to maintain the same survival outcomes, preserve the ocular anatomy, and now we're seeing preservation of visual function, and that deals with discussing radiation-related morbidity. So we'll talk about a targeted treatment strategy, we'll discuss alternative staging, we'll talk about fine needle aspiration biopsy. But this is really the bread and butter of what I want to leave with you today. None of us would miss this. This tumor is along the supratemporal arcade. It's brownly pigmented. You can see the orange pigmentation. You can see the feather margins, but the large surface coming up. And if you look closely, you can appreciate that there is an exudative retinal detachment. So small tumors have high risk characteristics, and this tumor has virtually every one of the correct diagnosis is for small tumors. Is it a large nevus or is it a small melanoma? And we've really had a shift in terms of how we manage over the last decade. And then I always go back to the collaborative ocular melanoma study. This is the only prospective randomized clinical trial data at all in the field of ocular oncology. And what's interesting is that we have good data from small, medium, and large tumors. The classification to me is so simplistic. It is small tumors are under 2.5 millimeters in thickness and less than 16 millimeters in base. Medium tumors are 2.5 to 10 millimeters in thickness, and large tumors are greater than 10 or have a base greater than 16. That was controversial. There's a bunch of new TNM classifications now, but essentially this classification, small, medium, and large, coupled with genetic testing that we'll talk about later, is as accurate as anything we do for diagnostic accuracy and for prognostication for the patients for survival. In the COMS, if you'll remember, there were 3 arms. One was the observational small tumor arm and 2 randomized clinical trials. The medium melanoma trial randomized the patient between enucleation or radiation plaque therapy. That trial took forever because you can imagine people didn't want to randomize to enucleation, but ultimately that trial completed and had enough enrollment to give us diagnostic certainty about the outcomes. And the take-home message for that outcome was that the small melanoma-specific mortality rate at 5 years was 1%. The medium melanoma 5-year specific mortality was 10%. And the large melanoma-specific mortality rate at 5 years was 30%. I hear some of my colleagues get up there and say, we have not made a dent in the treatment of malignant melanoma. 50% of our patients die. That's hogwash, okay? The bottom line is that survival is based on the entry into treatment, and the smaller the tumor is, the better the outcome is overall. And then even within large tumors, we now can subclassify based on genetics. The large tumor trial was interesting. It evaluated a hypothesis that Zimmerman, who was at the Armed Forces Institute of Pathology, thought that when we enucleated eyes, his argument was that patients were dying from surgical enucleation. And that was because he followed the enucleation outcomes, and the mortality would peak around 2 years. And he said, oh my God, we're killing our patients by enucleating them. It turns out that he misrepresented the data. He didn't do the appropriate analysis to stratify. So he did see the death rate, but it wasn't related to enucleation. But in that interim, when there was uncertainty, the large melanoma trial randomized between giving patients radiation for 1 week before enucleation or enucleation only. And we had shown that radiation before enucleation killed the potential of tumors or residual tumor cells in the orbit to expand. And that did show a difference. But of the 1,000 patients that were evaluated, it was a difference in 5 patients. So it was an incredibly small difference, and it was not statistically significant. So what we do now, we treat small melanoma patients early. We almost always use radiation conservation with brachytherapy for medium tumors. And for large tumors now, we're treating them with brachytherapy with radiation without having to enucleate in the majority of the eyes. Nonetheless, there are patients that have to be enucleated: secondary neovascular glaucoma, rapidly enlarging tumor, vitreous hemorrhage, total detachment, no light perception. So in the CMS, 1,500 eyes were enucleated. And in those 1,500 enucleated eyes, the diagnostic accuracy was over 99.8%. That really argued strongly that we make the diagnosis with incredible accuracy and certainty. That's important because all of our oncology colleagues, they don't do anything without a biopsy. But we had shown that we didn't biopsy patients that had classic melanoma, and this was the study that supported the lack of a need for biopsy. So the medium tumor trial take-home message: no difference between enucleation and iodine-125 brachytherapy. It's interesting how the glass can be half full or half empty. I looked at this result and said, we're plaquing everybody. Everybody's going to have brachytherapy. But some of my colleagues looked at this and said, wow, enucleation is really great. Let's do what we do. So the same data with a similar outcome can be interpreted very differently. That speaks to a lot of the data that's coming out for clinical trials. You really have to look at what the sort of focused bias is of the participants. We know that less than 1% of patients that you look at with a medium or large tumor will have evidence of melanoma-specific metastatic disease at presentation. So you do not need to work your patient up for melanoma metastasis before they're treated. But you need to recognize that 1 in 10 of your melanoma patients will have another malignancy, an independent secondary malignancy. And for women, that's typically breast. For men, that's often lung. Many of them will know they have that malignancy, but for our patients, our men with lung cancers, about 2/3 of them have no idea that they have a lung cancer at their presentation. So we do not do preoperative screening prior to brachytherapy or enucleation for our patients unless there's a specific concern. The large tumor trial, looking at Zimmerman's hypothesis, the take-home from that was there was no significant difference. So that allowed us to eliminate external beam radiotherapy, and it clearly showed that enucleation was not associated with tumor cell dissemination. But the take-home message from the large tumor trial in particular was, we know exactly where this tumor metastasizes. It is liver, 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 liver. And then it's lung, 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 lung. And then a few patients get this unusual subcutaneous tissue or bony metastasis. But when you think about where you're worried for your patients, it's liver first and lung second. So we know that you can manage small, medium, and large tumors, and we see that there's this trend toward moving away from enucleation, but there was still really big concern about what to do with small tumors. And the first National Institute trial that I submitted was rejected because the argument was you can't tell they're a melanoma. So that deals with diagnostic accuracy, and it also dealt with concerns that radiotherapy may not be effective for small tumors. And that has something to do with the way the Monte Carlo dosimetry is calculated to give the dose to the tumor in small tumors. So we had talked at the time about different approaches for melanoma using sandwich therapy. That's something that was being done in the ocular oncology field, where they would give surgical resection coupled with chemotherapy, or they would do a biologic with a chemotherapeutic agent. So it was using two different pathways to treat the tumors that you manage. And that's important to know because in spite of these excellent results, we're still concerned about metastatic disease. So there's two things you want to take home from treatment. You want to know what is the incidence of metastasis, and you want to know what's the local tumor control rate. In the COMS, the local tumor control rate was not the mortality rate. The local tumor control rate was about 90%. I'll argue that that's incredibly low. Our local tumor control rate in the practice that has been monitored now for almost 3 decades is virtually 99.5%. So we know that local tumor therapy works. It's not like you treat these tumors and then at 5 years or 10 years, at 15 years, the tumor starts to recur. That is not the case. So these tumors incredibly well respond to radiotherapy. Specific mortality rate, we said 1% for small, 10% for medium, 30% for large. In the COMS, because they didn't know this dosimetry issue, they did something that we no longer do. They used a dose of radiation, but instead of treating that same radiation dose to the height of the tumor, irrespective of the tumor height, they said, if you have a tumor that's under 5 millimeters, we're going to treat it as if it's 5 millimeters thick. So I argued for a decade that we were over-treating tumors under 5 millimeters, and that turns out to be true. We've looked at data now, and we don't need to do that. We treat every tumor to the thickness of the tumor, and that is allowing us to be precise with radiation delivery. The COMS study excluded tumors within 1 millimeter of the optic nerve. We treat those routinely now with the plaque that has a notch in it. I did 2 of those today, and you slide the notch right around the optic nerve. And we know that the key to any radiotherapy is that you have a good margin. And the margin we use is 2 millimeters. So if you have a 16 millimeter tumor, the longest basal dimension, we use a 20 millimeter plaque. We want 2 millimeters on each margin, so it's a 4 millimeter coverage. So we treat to 20 millimeters. And at our operating room, and what we did today is we use ultrasound in the OR that allows us to know exactly where the plaque is over the tumor. So combined modality treatment therapies, we know that we have excellent local control. We're interested in decreasing morbidity, and we want to extend the therapeutic window from medium tumors to large tumors to small tumors and to tumors against or adjacent to the optic nerve. There were many approaches to this. The Shields group in Philadelphia at Wills is incredible, and Jerry and Carol are phenomenal. Their approach is they use brachytherapy, they put the patch on, and then they use laser treatment in the clinic every 3 months, typically for 3 cycles. And that's called adjunctive transpupillary thermal therapy. Some people will do the brachytherapy and just do a single laser photocoagulation. There's a group in England that was doing lamellar resection. They would cut the tumor out of the eye and put a plaque around the base of the tumor. That was Bertil D'Amato's work. Virtually no one is doing that any longer. The group in Spain and Barcelona was actually taking a vitrectomy cutter and cutting the tumor out. The problem with cutting the tumor out with vitrectomy and the resection was that the margins had very high recurrence rates. So that's really not acceptable for this. What we were able to look at was we did the standard brachytherapy. We looked with ultrasound in the operating room, made sure we had a good margin, And then we injected anti-VEGF at the conclusion of the brachytherapy. So the plaques that went on today will be on from Tuesday. I'll take them off Friday. When I take them off Friday, I'll inject the eyes with an anti-VEGF. And the reason we've done that is that it significantly alters the treatment course. So there were several good studies. Tumor burden that was looked at by Shields and David Abramson at Sloan Kettering and myself, we don't really see a change in the tumor burden within the first 3 months. So it's very important to reassure your patients that the tumor is not supposed to shrink right away. But by 6 months, we see about a 10 to 15% reduction in the tumor volume. And by 12 months, about a 24% reduction. So the tumor starts to shrink significantly. Remember, our small tumor had that retinal detachment with the exudative detachment. In the study that we looked at, we followed the retinal detachment rates. By 1 year with standard brachytherapy, a third of the patients still had a retinal detachment related to their tumor. So in our study, we did standard brachytherapy and we added the anti-VEGF at the end, and we compared that to our historical experience using the standard radiotherapy, brachytherapy alone. And all the patients had to have an exudative retinal detachment because that's what we were targeting. We were asking, could we cause the tumor to shrink faster? And could we cause the retinal detachment to resolve quicker? We had a group of patients in the series of large tumors, 26, mean age is 60 for this group, and we followed them through the first year. We get a lot of Hispanic patients in this series. Remember that darkly pigmented patients have very low incidence of melanoma. Melanoma is typically associated with fair skin pigment, light colored irides, sun exposure, and it falls into that European Norwegian heritage. So in this study, randomized across this group, the mean thickness at presentation was 4.8 and the mean base was 14. So these are typically large medium tumors. All of them had a retinal detachment. The 85 gray is the amount of radiation that we deliver to the apex. So remember, this plaque is sutured on the wall of the eye, and it radiates through the wall of the eye to the tumor. And what you're interested in is, at any point, what is the lowest dose that any tumor cell receives? And the key to that is you want that lower dose to be no lower than 85 gray. And that's the way that's done with the margin. And if this plays, which it doesn't look like it will. So this is the brachytherapy. Here's what a plaque looks like. You can see it's got 3 stay sutures. It's sutured on the wall of the eye. The cornea is rolled way over because the plaque is very posterior. This is what the tumor looks like. And then here is what the plaque looks like with ultrasound in the operating room around the tumor. So here's the tumor and here's the plaque. And you can see how nicely centered the plaque is around this tumor. So that would be excellent centration. And we do that 3-dimensionally by the rotation of the ultrasound probe. So this is one of those patients. She has a larger tumor in the group, 67 years old. You can tell she's lighter pigmented tumor, orange pigmentation, exudative retinal detachment, thickness of 4.1, base of 16.5. This is what the ultrasound looks like. Ultrasound is very helpful in looking for that collar button or mushroom shape. It's very helpful in showing the retinal detachment. Often there will be some what we call choroidal excavation or shadowing. And then that's your B scan. And then of course, A scan allows you to look intrinsically at the reflectivity of the tumor, and you expect the melanoma to have low internal reflectivity. So here we are 6 months later, the tumor has shrunk by its base and its height, and the retinal detachment is resolved. And you can see here that the tumor base has decreased, the detachment is no longer present. And this patient actually recovered excellent vision because the tumor was temporal and regressed away from the macula. This is the group data. So when you look, red is brachytherapy alone, blue is brachytherapy plus an anti-VEGF, in this case bevacizumab. And you can see that 1, 3, and 6 months, there's significant acceleration in tumor volume reduction. Exactly what you would hope to see for a combined therapy. But even more striking, and this is really the reason I was interested, is the retinal detachment rates virtually were resolved within 6 months of treatment with brachytherapy plus the anti-VEGF. And you can see with brachytherapy alone, 85% of the patients still have a detachment at 6 months. The detachment is what leads to the compromise of the visual acuity outcome for the eye. It also leads to a more likely development of neovascular glaucoma or need for secondary enucleation. So this was the data that shifted us to couple brachytherapy with a single injection of anti-VEGF at the removal of the plaque. Incredibly simple idea and incredibly simple concept. So this study group of 26 patients had 100% tumor control. Nobody died from metastatic disease or developed metastasis in that 5 years. That's pretty remarkable. Tumor reduction by 30% and 100% resolution of the retinal detachment. One patient developed a later retinal detachment in that eye. When they started in the study, the vision was 2100. And I told you I was really interested in resolving the retinal detachment. And the reason why is that the retinal detachment is responsible for a significant component of the visual loss. So this group went from 2100 to 2030 by 6 months because of the resolution of the exudative detachment. And we had no complications with the use of bevacizumab. So it was kind of a win-win for our patients. So that is for us a standard of care. You'd think maybe that would be a standard of care everywhere, and I can tell you it is not. I think my colleagues in ocular oncology are very difficult to move from one treatment strategy to another. And I think that's something that we try to focus on, is trying to incorporate best practices as safely and as quickly as we're able to. Now,
Tim, I think we might just launch a poll question here, if you don't
Sure.
mind.
I love it.
Let's launch it. For active intraocular malignancy, enucleation is the preferred treatment. Is that true or is that false? And Tim, as everything is coming in, there was a question in the chat. I think I know I can direct this.
Okay.
What percentage are prostate metastasis?
So surprisingly, remember, prostate cancer is a significant cancer morbidity in the male population. And what's happening is the reason why we're seeing more of these metastatic presentations is patients are surviving their tumor. So when I started, you died from breast cancer metastasis typically within 4 months of metastatic disease. My breast cancer patients that present to my office now, I expect to have them alive and sighted for 5 more years. Huge shift in the survival curve. But with that survival curve has come an increase in metastasis. So prostate, even though it's an incredibly large proponent of the tumor within the United States, within oncology, it's a very small component of metastasis to the eye. So it's very interesting that prostatic metastasis is rare. When it metastasizes, it sometimes can have an unusual color. It can be a little reddish. It can have an orange pigmentation color, or it can be amelanotic. It's important to remember that brown tumors, think melanoma, 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 okay? And it's important to recognize how important color is in this. So somebody still wants to enucleate, but most of you understand that we've really moved away from enucleation to radiotherapy, and that would be the take home for that. Now, when we go back to this slide here, one of the problems in ocular oncology is there are so few patients for us across the nation. So all the studies typically are single institution, they have small sample sizes, and follow-up can be limited. And within all of our practices, as we presented, there's often a unique treatment approach. If you take one thing home from tonight, remember this. This small tumor controversy, I think, should have moved on. So the question was, what do you do with small pigmented choroidal lesions? And it was controversial, as I said, because of diagnostic accuracy, concerns of the efficacy of treatment to control the tumor, and then the worry that these patients were going to unnecessarily lose vision if you treated a patient that had a nevus instead of a malignancy. we're blessed, I think, because we have really excellent abilities to identify and accurately delineate tumors with wide field imaging, with OCT, with high resolution ultrasound A and B scan. We have, and the most important thing for us is we can see these tumors directly. There are very few malignancies in the oncology field where you actually get to see the malignancy. One of those that we see is melanoma for the skin, totally different disease, sad that it shares the same name, metastasizes to a different place. But remember, when you go see your dermatologist and you have an atypical pigmented lesion, they don't say, let's think about what to do. They have the luxury that in most instances, they can take it right off and look at it histopathologically. We really didn't have that ability short of enucleating the eyes. And most of the patients presenting with small tumors present with excellent visual acuity. So there's the controversy, the sort of nuggets of concern with treatment. And that goes back 3 decades. The COMS did something to evaluate that. They did a small tumor observational study. They had 188 patients. What they saw was a third of their patients grew by 5 years. The melanoma specific mortality rate at 5 years was 1%, but by 10 years it had increased to 8%. And the things that were predictive of malignancy were the largest tumor size at presentation and whether the tumor grew. So we don't want now to predispose our patients to metastatic disease. So you're seeing a shift away from observation to early treatment. So, we good?
Yep, I got it.
Okay, so this study was, what could we do? So when I went to Bascom Palmer, it's interesting that if you went back 60 years, every patient that presented with a pigmented lesion was thought to have a melanoma, and those eyes were enucleated emergently. And that actually was the standard of care. Bascom Palmer with Dr. Gass and Dr. Norden really played a role in changing that standard. What Dr. Gass and Norden said was, let's take a look and see if we have to enucleate these patients right away. Maybe for smaller tumors, we can observe the patient. And so they did some observational data, but it was very small sample size.
No, he wants you to unmute.
I got it, Tim.
So what I suggested was that we would start off with patients that had small tumors that traditionally were not being treated. That's tumors under 2.5 millimeters. We made the patients have to have a tumor that was 1.5 millimeters thick to 2.4. So thick enough that we could follow it and measure it, and small enough that it didn't fall into the medium tumor criteria, which we already knew should have been treated. And what I did from 1991 was I followed 154 patients.
Now I'm muted.
So the risk factors for that and the outcomes were critical. And what we saw was that if you watched these patients and we specifically defined what was the growth in both the thickness and the largest basal dimension using ultrasound and imaging, we evaluated these patients literally every 4 to 6 months. We did ultrasound on every visit, wide field standard photography on every visit, and A and B scan echography on every visit, and did our standard evaluation. Of this group, the entry was 54. So see, that's a little younger than the group we talked about just recently that was 59. So we've got smaller tumors, and it turns out those are younger patients. We followed this group now for over 10 years. And what we saw was that of those 150 patients, essentially 50 of them grew, about 30%. And that correlated with what we had seen in the small tumor observational study. Of the patients that grew, that was this special group, we treated them immediately with brachytherapy. And the take-home message was that those patients did very well. What are the presenting signs for small tumors when they present? It's important to know that because this is what burns everybody that's a primary eye provider. 2/3 of the patients really have no symptoms. And when they have symptoms, they're incredibly nonspecific. They'll say they have a little metamorphopsia. They'll say they have photopsia or floaters, things that our patients complain of almost routinely if you ask correctly. So no specific presentation signs or symptoms for these patients. Typically, smaller tumors are more posteriorly located. That's good because we see them, but 1/3 of the patients had anteriorly located tumors. We're seeing more and more tumors that are within that margin close to the optic nerve. Those are concerning, but effectively are treated well. And the most common characteristic of the tumor itself was the thickness of the tumor, the basal dimension of the tumor, the presence of orange pigment on the tumor. That's that lipofuscin that we can see beautifully now with infrared imaging. Exudative subretinal fluid, about a quarter of the patients. And then some of the patients can have these chronic changes that can lead to secondary pigmentation because the tumor has been present for so long. So how long did we watch those patients till we treated the group that changed? A little over 3 years. That puts them right up with what we saw with that other tumor group. And the height went from 2.1 to 2.8. That's a pretty significant growth in tumor size for me. I'm not happy with that anymore because that tumor now has gone from a small tumor to a medium-sized tumor, and that does have some impact. So a 0.7 millimeter increase in the apical height, and I think that's most important, and a 0.8 millimeter increase in the base. But when we treated these patients, we used exactly the same brachytherapy that I've showed you, 85 gray, 2 millimeter margin, ultrasound localization. And the good news was that when we did this, as we saw, these patients did very well. Very well meaning what? Very well meaning their tumor was controlled, they kept their eye, and they did not develop a complication that put them at risk to die from their tumor. But what we realize is that when we put a radiation patch on an eye, we have really committed that eye to developing radiation complications. And the most common radiation complication is radiation retinopathy. We really look at it in our practice as radiation maculopathy. If the radiation retinopathy is not in the macula, it has less concern. That is almost every patient by 10 years. Radiation optic neuropathy, fortunately, is less common. We see that in about a third of our patients, and that typically is when the tumor is in close proximity to the optic nerve and the optic nerve gets a large dose of radiation. If the tumor is anterior, most patients get progression of their cataract, and it's hard to tell in some of these patients whether the progression is accelerated from their normal aging progression. Fortunately, some of these complications we don't see. We virtually see no instances now of tumor recurrence, neovascular glaucoma, or significant strabismus. In this series, one patient died. So that gives us a mortality rate from melanoma of 2.2%. That's a lot higher than it should be. And like everything else, there often is an explanation. That is the patient that dropped out of the study and came back 5 years later, and her tumor went from 1.8 millimeters to 9.8 millimeters in thickness. So she went from a small to a large, and that really emphasizes one of the take-home messages is if you're not going to send your patient with a pigmented lesion or a retinal choroidal lesion to a specialist, make sure you document it photographically. If you don't have imaging, draw it, measure it, either with ultrasound, or if you don't have ultrasound, estimate, and bring the patient back. So when I see a new patient, if I'm not going to treat them, they typically return in 3 months, and then every 4 months for a year. And then if they're stable, I'll move them to 6-month follow-up. But where people get burned is when they go past 6 months in the follow-up and the tumor changes, and then you are at some exposure of a management that fell below what the perceived standard of care is. So bottom line for this is I still tell our group that we can watch patients. I virtually watch every patient with a small tumor from the first visit. I rarely take a small tumor patient and say, we're going right to the OR. I image them, I talk to them, I give them some of the concerns and the risks, and I bring them back, and it allows us to have a better discussion on the next visit about what the benefits to earlier treatment might be.
Hey, Tim, I think this might be a good place for a poll question, if you don't
Perfect.
mind.
Love it.
Okay, we're going to launch it. The best management for a pigmented tumor of 1.9 millimeter thickness in an adult is enucleate, radiotherapy, vitrectomy for a biopsy, observation, or referral to ocular oncology.
Hey, Tim, this is Greg Caldwell. And
Hey, Greg.
I have a quick question for you. You were pounding that metastasis to the liver, to the liver, to the liver.
Yeah.
And the question that I have is, does it do that because there's minimal lymphatics in the eye? So it uses the retinal circulation, maybe the venous system, the retinal venous system, and going to the liver. Is that a good way of thinking about that? Or is it just, we
Right.
don't know why?
So we do actually have some good data. There are now organ-specific tumor metastases. So there are a variety of different tumors that we now specifically metastasize to one organ or another. And when you look at the cell surface markers, those cell surface markers are specific. Now, the argument in the past wasn't really for the specificity. It was, this is hematogenously disseminated tumor and your liver's filtering everything. So that's where it's going to go. It turns out it's not that simple. You can inject melanoma cells in animal models and they will preferentially go to the liver in almost every instance. And I will tell you that I hit liver because if you see a lung lesion and you think it's melanoma and there's no liver involvement, you need to think hard. So though we don't biopsy our tumors, I will tell my surgical oncologist who's looking at a chest lesion that before they think it's a melanoma, when the liver is free of disease, that they need to think other things. For example, remember, 1 in 10 of these patients have a lung lesion, a primary lung adenocarcinoma. And then for women, they could met from their breast adenocarcinoma. We talked about colon and prostate. So it's important to realize that you can't just blame everything. It's kind of like this whole thing that if you come into the hospital with COVID and you died from COVID. So that just is an assumption that's kind of easy to make. And I think in many instances, it's a little bit naive. So I get very involved with the oncologists when my patients present with metastatic disease, because they're often thinking one way when I'm really thinking another. Okay, so I'll tell you that for our poll question, you're never wrong to refer a patient that has a lesion of that thickness. I would tell all of you that unless you're specifically interested in managing those patients yourself, those patients should be referred. If you're not going to refer them, you're going to watch them, and you have to have the ability to watch them closely. Those are the patients. I do some medical legal consulting, and I've represented a number of optometrists for patients that have developed melanoma, saying that the tumor wasn't missed, and to the best of the notes and the imaging, there was no tumor. So those were easy cases to defend. When you get in trouble is if you document the lesion and you don't follow it, and the patient has a bad outcome. Everybody's looking for who's to blame, and the first person they'll think about is the person that saw the tumor but didn't manage it. So for me, the two correct answers here would be refer, observe, but document well. And then when it goes to the ocular oncology practice, it's likely going to be treated with brachytherapy after a short course of observation. So you got to love those questions because there's a lot of right in all of those.
And there's one little quick question. Is
Sure.
CAR T therapy utilized for melanoma of the eye?
No. So CAR T therapy has not been utilized for melanoma of the eye. And one of the reasons it hasn't is that, first of all, it's an incredibly complex therapeutic strategy that you have to have a library of the tumor response characteristics for the cells that are used for the CAR T therapy. And the problem is that the tumor burden in the eye, remember, we're talking, when we look at a large tumor, that is the smallest cancer anywhere else in your body. So most of the tumors that I see in the small medium group are not imaged by MRI and CT, and they're not imaged on PET. So it's not at all uncommon for somebody to get a tumor in the eye, say, okay, I'm sending you for MRI, CT, PET, whatever you get. It comes back and there's nothing there, and you tell the patient it's okay. But that's not correct, because lesions that are under 2 millimeters are often missed on every one of these modalities of scanning. And then the other thing I'll tell you is if for some reason you are sending your patient out for imaging, make sure you look at the scans yourself. Don't let somebody interpret, because you may look and they may have called it normal, and you may look and say, look, there's a little blister right there. That's the melanoma or whatever lesion. But we see tumors at a size that is so much smaller than any other oncology practice. And the good news for that is size matters. So if you got a smaller tumor, why do retinoblastoma and melanoma patients do so well? Because we get to treat them way early in the course of the disease compared to our colleagues that get large tumor burden, multiple organ involvement, and don't have the opportunity to follow with the precision that we do.
Tim, here's a question that came in. I think it's I think a really good question.
Good.
I know how I would answer it. Who should I send a suspicious choroidal nevus tumor if I do not have a B scan or OCT? A retinal specialist or to you? And maybe not specifically to you, but another ocular oncologist. I would send to you, Tim.
Right. So Joe, I appreciate that, and you guys, I will tell you, I'm always happy to see those patients. That's a referral that makes me smile, even if I'm giving the patient good news, right? So I think that is important. Remember, I think that you have to be really focused on who you refer to. So refer to somebody who has some expertise and interest in whatever you're referring, okay? You wouldn't send a surgical patient to a medical retina specialist because that would not really benefit you. So I would say there are retina specialists, and I'm a retina specialist, that do oncology. And then there are people that are ocular oncologists that really only do oncology. I think you need to send your patients to that patient that has an interest. So this is not a routine referral to any retina person. And it certainly doesn't help you to refer that patient to a comprehensive ophthalmologist. I think you guys have done that evaluation and have made that decision. You don't need to go to another specialist. I would step right up, and if you have access to somebody like me that has an interest, refer that patient directly to me. If you have somebody in the community that has a tumor interest, let that be the person you refer to. And try to get an idea of how much tumor they see. When I did my tumor training, for example, in Milwaukee, I see more tumors in a week than I saw in a year of my fellowship. And that was a fellowship that was at a tumor center. So there are very high volume practices, and there's about 4 or 5 of those in the US, and then there's some less high volume practices. I think what you do often, you do well. That's one of my take-home messages, and that's how I feel. So hopefully that's helpful. But remember, once you've referred, even if you refer to a non-tumor retina specialist, that's changed the dynamic of your level of responsibility. So you've covered yourself in that manner already. But for the patient's best care, I would try to get them to a tumor specialist.
And Tim, in regards to OCT, what image is best for viewing a lesion?
So, that's a great question. So we're getting OCT now that is steerable. So Optos, has a steerable OCT component where you can actually do OCT in the far periphery. We can get OCT now out to the aura. So if you're lucky to have that, you're lucky. If you have the ability to image over the tumor itself, that's what you want to do. I like Heidelberg's imaging for macula best. Zeiss is my second favorite. If it's a tumor in the periphery, I use the Optos with integrated OCT. What I'll tell you is the OCT is the less important study for that than it is to realize the limitations of your study. So one of the things to know is that you have to look at these patients. So we had 3 patients in the last month that were referred from retina people with a diagnosis of melanoma. And they sent beautiful Optos pictures of the tumor. And it was this beautiful brown tumor. But what did it look like when you looked at it with the indirect ophthalmoscope? It was red. And it was a choroidal hemangioma. So I saw 3 hemangiomas. My patients loved me because imagine they come in, I've got a melanoma, everybody's Googled it, they think they're gonna die, their eye's gonna be enucleated, and you say, look, you do have a tumor in your eye, but thank God it's not a malignant tumor. Now it's a concerning tumor, but it's not a malignant tumor. So the red-green lasers in the opto system give you pseudo color, and that pseudo color often is mistaken. So I'm a big proponent of look at the patient with the indirect, and if you're not comfortable, make sure that you get somebody to look at that patient. Now, having said that, I don't care. If you've got a patient with a tumor and you send them to me, whether you got the diagnosis right or wrong does not matter to me because you got the patient to me. And I think that's really when I talk to my patients, it's never about what the doctor didn't see. It's about the doctor talked to you about what they expected, then they sent you to me. That's why you're here. And we're able to use some technology that's unique. And this is what you have. And the nice thing about ocular oncology too is 99% of the time, I get to look at the patient for the first visit and we make the diagnosis and we have a treatment plan and as they leave. We don't have to send them to CT, get lab work, get a chest x-ray. We really have the luxury of seeing what these patients have. So my thing would be if you have a lesion in the choroidal retina that has intrinsic thickness, it has any thickness at all, have somebody within the retina or ocular oncology community look at that patient. You're never wrong with that. If it's flat and you feel comfortable to watch it, then watch it. But remember, watch it on a schedule that protects you as well as the patient. If it's the first visit, do 3 months, go to 4, then go to 6. I never go past 6 months with my tumor patients because things can happen in a year that really change the management. So radiotherapy for small tumors is incredibly effective. We can judge very small growths incrementally in height and base. We can look at these patients now with OCT wide field imaging, like Joe was asking, that allows us to see in a way that is totally unique. Rick Spade made this statement at one of the meetings that we don't need to use ultrasound anymore because we've got OCT. But OCT is really limited by the blockage of transmission from the tumor itself, doesn't image the posterior margin of pigmented tumors that are thick. And the other thing is that we don't have any corollary data yet. So I can tell you all of the data related to ultrasound measurements, and I can tell you there's virtually no data related to size measurements on OCT, and they are very different. They measure very different things. So then the other thing I told you is if 100% of our patients that get treated with radiation by plaque develop radiation retinopathy, why do you bother to plaque them? And some of my colleagues said, they're not going to see, they're going to be blind. There's no benefit, take the eye out. I found that distressing, and that led to this study. This was the first randomized study to compare anti-VEGF treatment approaches in radiation retinopathy. So we've said that the major reason patients lose vision that is associated is radiation retinopathy and optic neuropathy. It's dose dependent, but virtually all patients will develop retinopathy when followed long enough. It doesn't occur immediately after the plaque. There's a delay. So what we think is that you get an immediate vascular injury, and then you get remodeling that leads to a compromise in that parasite, leading to a lack of integrity of the tight junction, and then those eyes leak fluid first and heme later. We were really big at adopting intravitreal anti-VEGF therapy for these patients early. Virtually no one was willing to do this because the idea was you're not going to stick a needle into a tumor-bearing eye. And that's what we do now routinely. And there were no standardized protocols. We talked about the incidence. In the COMS, by 5 years, 50% of the people had evidence of radiation retinopathy. But what did that mean? What it meant was that on color photographs graded at a reading center, half the patients had radiation retinopathy. If you do SDOCT, which all of us do routinely of the macula, we see by 24 months, almost 100% of patients have retinopathy. So retinopathy is rampant post-radiation therapy. And you can imagine the higher the dose, the more significant the retinopathy. That means increased tumor thickness, close to the optic nerve or fovea. And if the patient has underlying associated vascular disease, hypertension and diabetes in particular, they have a higher incidence and more rapid development of retinopathy. So the first study I did was with bevacizumab, and in that study we did first bevacizumab, then we incorporated triamcinolone and did combination therapy. We used 139 patient eyes, all with consent and long-term follow-up. They were all treated the same way. What we did not do, which is one of the things that people are doing now, is Ivana Kim at Mass Eye and Ear and Carol Shields have talked about doing prophylactic anti-VEGF therapy. Well, they'll inject on a schedule every 3 months after plaque. We can tell them that's not necessary, because if you follow your patients until they develop OCT imaging consistent with radiation maculopathy and treat at that point, the outcomes are identical. So you don't need to treat them before their disease, but you need to follow them and treat them as soon as retinopathy is detectable. And so same picture, here we go. We graded the maculopathy. We used a variation of the Wills system, and patients had to have either intra or subretinal fluid involving the macula itself. And in this study, you had to decrease your vision. So you could have been 20/20 and now we're 20/25, but you couldn't be 20/30 and now you're 20/20, but you haven't, we didn't include those patients. We wanted to be very clear. And remember, this is a total off-label use of both the anti-VEGF and the steroid, because there are no on-label indications. We knew that we couldn't wait. When some of my colleagues started doing anti-VEGF therapy, they injected and they brought the patient back 6 months later, like they did with their patients for follow-up, and they injected them again, and they couldn't understand why it wasn't working. As a retina specialist, I know that for neovascular AMD, if I inject the patient once and 6 months later I inject them again, they all lose vision. So you can give the right drug, but in the wrong way, and that's the key. So we've done some really exquisite studies trying to look at interval. We started off at 4 to 12 weeks. In these 139 patients, the vision was 2100 plus. Extensive foveal thickness, almost 500 microns. The follow-up in this series was almost 5 years on average. In this study, the interval to documented visually significant maculopathy was 10.8 months. We now know if you just look at maculopathy without compromising vision, we may see that as early as 6 months. And then we followed them extensively. This is a 76-year-old that's been treated with brachytherapy, had a medium-sized melanoma. You see the melanoma here, and you can see there's leading edge changes at the margin. This patient noted a decrease in vision over 6 weeks, came in to see us, and you can see that when he saw us the first time, this is what he looked like, very little changes, and then he gets injected, gets better, and gets better. And he ended up after the study, starting with 2100, ending at 2030. And this is the first year of follow-up, and then he maintained this. Now look, this is not a normal macula. There is still lipid here, there is still edema. So in many of these patients, they have significant improvements, but they have persistent vascular compromise, and these patients need to be injected over and over and over again. And for us, the average interval for injection for our study was about 6 weeks. You can see the same thing here. This is more extensive. There's extensive lipid alteration here. There's subretinal fluid in the area. The tumor looks great. It was a very large tumor. The size had decreased. The patient's a year and 2 months after the initial brachytherapy, 5-week decline in vision, and comes in. And again, you can see here's the OCT, gets worse. We inject the patient now and then improves. And this patient ended up with 20/20 vision and fluctuates between 20/20 and 20/30.
Tim, a question came in. What effect, if any, does anti-VEGF injections have on melanoma progression or growth?
So that's a great question. So you guys don't know, but may know, the person that developed anti-VEGF, isolated anti-VEGF, and postulated its treatment was not interested in treating the eye at all. He was interested in treating melanoma that was metastatic. So it turns out that it doesn't do very well for that. but it does incredibly well for vascular compromise from radiation or a variety of other conditions like neovascular AMD or diabetic macular edema or occlusive vascular disease with stroke with branch or central retinal vein occlusion and macular edema. We've looked really closely at the patients, and we're injecting a very large number of patients with anti-VEGF now. We're not seeing any significant change in the tumor. Where you do see a change is even in some of the patients that have an atypical nevus that we have not treated yet, but the fluid is involving the fovea, we'll inject them, and that fluid can resolve without the tumor changing at all. So this is targeting vasculature within the tumor and associated with the tumor, but it doesn't change the size of the tumor itself or the volume of residual tumor. But that's a great question. And that's what he thought he was going to do when he developed this. So he would have got the Nobel Prize for this, of course, but he passed away before the prize could be conferred, and you have to get the Nobel when you're living. So he missed out on that one. Remember, almost 500 microns by 2 months down to 380, by 5 years down to 314. P-value is markedly significant. Long-term follow-up. Vision improves from 2100 to 2050 and goes back and forth between 2040 and 2060. You can see about half of our patients are 2040 or better. The average number of injections in this study was about 5 anti-VEGFs and 1 to 2 intravitreal steroids. All the patients were alive and well. 2 of them did develop metastatic disease. That's kind of what you would expect. Nobody had failure of local tumor control. There was some concern actually that maybe anti-VEGF would lessen tumor control, not actually reduce the tumor, but in some way allow the tumor to escape the radiation treatment, and we haven't seen that. So again, small studies. So in this study, we had significant impact by early and aggressive repetitive anti-VEGF therapy, and in patients unresponsive to anti-VEGF, the use of intravitreal steroids. The biggest thing to know is you need to look at these patients often. And Joe, when you asked, this is where OCT is critical, and it's not OCT of the tumor that's really critical, it's OCT through the central macula, because that's what compromises vision. And I'll tell you that we've done a branded drug study that was sponsored for Eylea, and Eylea works beautifully for this. Brolucizumab works beautifully for this. But since all of these are off-label, the only one that we can get coverage for to this date has been bevacizumab. And I think that's because it's such a low cost that the insurers have been willing to evaluate that. The DRCR network is proposing an anti-VEGF study going forward. And I think that could be very exciting because that will be much more broadly applied than the studies that were done by my group and Will's and the group at Mass Eye and Ear. And then my favorite new thing that I'm going to talk about is it became obvious to me that radiation therapy was excellent in controlling tumor, but had the sequelae of radiation complications that really altered the outcome for the patients. And we've struggled to treat them. But the question was, is there some way to manage small tumor patients in a targeted manner that could avoid radiation therapy entirely? And that's where really the last decade of my focus has been with small tumors. So we're going to say that when I was in 2016 and we looked at this, I was like, here's what's going on. We're kind of worried. In 2021 now, we have just published our 5-year outcome data for this approach, and I'll give you an update on that. So here's that small tumor that we talk about. And what I think has really revolutionized our understanding of tumors has been advances in the evaluations of the tumor genetics. You can do cytogenetics. That's what Bertill's group does in England. That's what Carol and Jerry do at Will's. Or you can do RNA analysis with PCR, which is what I do. This was the test from Castle Biosciences that Bill Harbour played a major role in developing. Why do I like this test? It's incredibly simple. It's incredibly precise. And it has a virtual 0 failure rate. And that's really critical for these small tumor volumes. What's the take-home message? You tell your patients there's two things you're interested in. There's two major classes of tumor. There's class 1 and class 2. You do not want to have a class 2 tumor because the mortality for metastatic disease for class 2 tumors at 5 years is 72%. The melanoma specific mortality for a class 1A tumor at 5 years is 2%. So molecular classification defines a 2% mortality rate and an almost 80% mortality rate. Class 1 is broken down in 1A and 1B. 1B is not quite as good. It has a different escape mechanism for metastatic disease, but you really want to be able to understand class 1 and class 2. And that's the first data that came out in 2011, and we have even better data going forward. So what I said was, I'm a retina surgeon and an ocular oncologist. And because I had operated on a lot of melanoma patients because of issues after radiation therapy, I really felt that we could effectively operate safely on these patients with small tumors. And what we were able to do that was the biggest advance is that, remember, the vitrectomy instrumentation, those instruments have become incredibly minimized. They're very small, 27, 25, and 23 gauge. And we use what's called a valved cannula, which is really fascinating. It's simply a flap over the trocar that you pass your instrument through to prevent fluid from egressing outside of the eye. So it eliminated the concern of, can I spread tumor cells outside of the eye? That was my big worry. And then what I suggested was maybe we can just laser these tumors, pull off the scar tissue from the tumors, stick a needle in to do the genetic biopsy, and then suppress inflammation afterwards. And maybe that is an effective approach primarily to the management of small melanoma. And so that was our study. We'll talk about the first 50 eyes. We reported on the first 100 eyes now with 5-year follow-up. In the gist of things, that's not a big number, but for studies of this nature, it's pretty large. Every one of these patients in this 50 had been observed and the tumor had grown, and or the detachment of the retina had increased from exudation. 68 years of age in the 50, you can see that all of them had this retinal detachment, which we think is a critical factor. Tumor size increased in 2/3, and the entry vision is 20/80, and look at the height. So I'm going to tell you it's important to see that the largest tumor in this series was 2.9 millimeters. We do not do this approach for tumors that are greater than 2.5 now, because we had a failure in the 2.9 group. 20/80, long follow-up, standard surgical approach. I don't think my videos are playing today. So here's the optic nerve and the fovea. You're going to go in, you clear the vitreous debris, you clear the hyaloid. It turns out the hyaloid is attached to these tumors routinely, so you have to elevate the hyaloid. Then we stain the ILM. We peel the ILM with ICG grease staining. We laser the tumor with a margin around the tumor itself, and then we stick a 25 gauge needle in, and we do it over and over and over again to get a multi-pass biopsy. That's passed from the field. The volume of the biopsy is usually about 50 microliters, incredibly small. And then we process this with a genetics buffering solution that breaks down the RNA, put it on ice, and ship it to the one laboratory in California that does this. This was the first patient that I did. You can see the laser over the tumor, and here's the biopsy site. I went here and you can see it extended through. This patient's vision was 20/70. The tumor height was 1.9. On post-op day number 1, just lucky, 20/40, good pressure, amazing result, and the exudative detachment had resolved. This is what that OCT, here's the needle track. You can see it posterior into the tumor. And you can see that this retina over the tumor was under significant stretch. And as soon as the needle went in, it kind of opened around the needle. That's not the needle trauma, that's the tension. You can see the subretinal fluid. And this was the first OCT analysis of tumor biopsies in melanoma. Now, unlike the other picture, this is the biopsy site. You can barely see anything. Laser over the tumor, sparing the fovea, 2100 vision, 1.8 millimeter tumor, vision is improved, and the follow-up, and you can see this biopsy site. Now, this is interesting, and we see this often. This is a plug of the triamcinolone acetonide that's injected. If you don't inject triamcinolone acetonide in these eyes, they have a significant inflammatory response, and it increases post-op inflammation and retinal detachment rates. So all of these eyes had traction, which nobody had noted before. The detachment was virtually present in all of the eyes preoperatively, and we could see it in about 90% of the eyes intraoperatively. It often was small and at the margin, and we did not have any evidence of retinal tear or detachment. The apical height of the tumors were 1.4 millimeters from 1.9, so about a 30% reduction in the small tumor height. One patient in the group, 2%, had a progressive detachment of the retina. Everybody had a detachment, so it wasn't a new detachment, it was progression. And the vision improved to 20/30, and 90% of these patients were better than 20/50. That's different than the 50% of patients with brachytherapy and anti-VEGF that are better than 20/50. So these patients visually and anatomically do much better. No patient died from metastatic disease, good local tumor control rate, and then we learned about this inflammatory suppression with patients that we treated early. 94 of these patients, 4% had class 1 tumors, that's good. You can see 10% had this class 1B, that's the one that has the larger mortality rate within class 1. Only 4% of these patients had class 2. The thing that's very interesting now is that our class 2 patients, if we treat them with this technique, we've had no patient develop metastatic disease. So I just told you that class 2 tumors at 5 years had an 80% mortality rate. And now I'm telling you at 5 years, not a single patient with a class 2 tumor developed metastatic disease. We've fundamentally altered that. Why do I think that is? I think it tells you that early intervention, irrespective of bad genetics, is associated with an improvement in the outcome. Striking difference. Now, the other thing is, so when I started doing genetic analysis, I would do cytogenetics. I'd stick a needle in the tumor, I'd send it out for our cytologist to look at. My cytologist would come back 100% of the time and say, it's indeterminate. There's too small a sample. And I would look and it'd be like 5,000 cells. And 5,000 cells from an eye biopsy, that's like a huge. And the guy's like, no, I want a chunk of tissue. And I go, there is no chunk of tissue. This is an eye. So this was a game changer for me, that 98% of the time I could get accurate genomics from a 25 gauge needle biopsy on every patient that I biopsied. So what's the utility? We now know that we manage our class 2 patients differently. There's multiple studies that are looking at appropriate options for class 2 patients. When I started doing this, there was nobody offering any type of adjunctive therapy to class 2 patients. And so I was treating my own patients, which I wouldn't recommend for anybody to do. But for example, valproic acid, which is an anti-seizure medication, had a really good toxicity profile. So I put all of my patients on valproic acid. That's under clinical trial evaluation now in combination with Yervoy, ipilimumab, and alone. So we'll see. And then class 1 patients, if they're 1A, we just watch them with routine standard of care. I still see them. We still offer standard of care, but we don't use an enhanced screening profile and we don't suggest adjunctive therapy. So the take-home message for me is that there's been more change in my approach to melanoma within a major ocular oncology practice in the last 10 years than in the 30 years before that. And it takes place with a shift to smaller tumors, a shift away from radiation therapy, and an incorporation of tumor genetics, and the ability to alter vascular alterations associated with tumors and radiation. It's a really exciting time. This is a field that was static for decades. Sadly, what I think the hard part of this is sort of moving the needle of standard of care, and that's one of the things we're continuing to focus on. Every one of these single institution studies, same surgeon, small sample size, limited follow-up. Now,
Tim, before
yes,
you go on,
sir.
a couple things. What is for this treatment they were just discussing? What is the recurrence rate for class 1A, 1B, class 2? Is there recurrent? Have you seen recurrence?
So for tumors under 2.5 millimeters, 0 recurrences within the first 5 years. Most of us think that if these tumors are going to activate, They grow within the first 24 to 36 months. And there's been some data that from my lab and others that have shown that. So 5-year follow-up's really important. And Joe, that's such a good question, because I don't know if your audience is aware of that, but there's a small tumor clinical trial using a novel agent that's activated by photodynamic therapy. It's the Aura 011 trial. It's treating small tumors. And what they do is they inject intravitreally an agent that is a nanoparticle that is conjugated to activate when photodynamic therapy is applied. I've really pushed back a little bit, because their success rate within 2 years, they have a 24% tumor progression rate. The tumor progression rate for this is 0, and the tumor progression rate for brachytherapy is 0. So I've said, you guys have to rethink the approach to this. I mean, I like the concept. It's intellectually appealing to me, but the bar of control for this is really high. It's like a new anti-VEGF. If you introduce an anti-VEGF, and it's almost impossible to exceed the response characteristics of the existing anti-VEGFs. CAT trial showed really no difference between anti-VEGF usage when they looked at that, looking at Avastin and a branded drug. And so it's very interesting. The bar, I think, for small tumor management is incredibly high. I think if you, at the subspecialty day in Louisiana this last month, the discussion said that the minimum accepted control rate for a new treatment for small melanoma should be greater than 90%. I will tell you, for me, it has to be almost 100%. But that is a great question. So don't treat it if you can't control it, right? Then you get all the treatment-related consequences without the benefit of response. So I think that's great. Are there any other melanoma questions?
Nope.
Because what I'm going to do next is I'm going to show you pictures of retinoblastoma, just to let you see what I get to see, and it's kind of fun. So the next part is going to be a lot more show and tell than this part, which was a lot of data-driven discussion. And then we can interrupt anytime.
Okay.
So we've said melanoma is the most common primary intraocular tumor in adults. Retinoblastoma is the most common primary intraocular tumor in children. There's an argument that the incidence rate is increasing from 1 to 15,000, maybe to 1 to 12,000. There's a lot of argument about what that is. Remember, when I started, everybody got enucleated, then everybody got radiation therapy, then everybody got systemic chemotherapy, then this intraarterial chemotherapy started, and I'm going to take you guys through that journey. This is one of the most fascinating journeys for me, because there's no clinical trial data. So every other pediatric malignancy is evaluated with clinical trial assessment before any change in treatment is advocated. We've never had a clinical trial in retinoblastoma. So that means that we've moved to the field based on laboratory and patient data in a way that's kind of unique. I think it's a privilege to be able to do that, but it also is nerve-wracking at times. And remember that the mortality rate from retinoblastoma in your great-grandparents' day, my great-grandparents, probably your grandparents, was 100%. So this was a lethal tumor, and it was incredibly unresponsive to therapy, because often the diagnosis was made very, very late and enucleation was not definitive. So advanced tumors have been the focus for this. Remember, if you see a kid with leukocoria, don't think of anything but retinoblastoma first. It's not going to be retinoblastoma, but make sure you've thought about it and you've looked for it and you've excluded it. The second is about 1 in 5 kids have a secondary strabismus. Only about 5 to 7% of the kids come in with a painful eye. Most of the kids actually that come to see us that are seen early are seen because a parent or a grandparent noticed a change and communicated that to their primary care provider, but the primary care provider did not see that change, and the patient was referred at a later time. So I love this story. So you can see the leukocoria in my boy, and you can see the leukocoria in his dog. So the family didn't think anything of it. The dog's got leukocoria. Hey, our kid's got leukocoria. But sadly, this is retinoblastoma. This was a traumatic injury to the eye. You can see here leukocoria. Here's leukocoria, and if you look, you can actually see the vessels in the tumor itself and secondary strabismus for this patient. So if you see this, man, push the buttons for referral and think retinoblastoma. When we see these tumors, the really small tumors are almost undetectable. They start off and they're not this white tumor that we see with calcific necrosis. They're this translucent kind of fish fleshy tumor. There's intrinsic vasculature within the tumor itself. One of the things that's helpful is if you have an ultrasound, tumors often have microcalcification, and that can really highlight a lesion in the eye. So ultrasound in these kids is very effective. Ultrasound is better than CT and much better than MRI. So this is our child. Here's the tumor. You can see the kind of reddish, fish fleshy appearance. Here's some dilated tumor vasculature. Here's that central calcification. Here's the tumor, fovea, optic nerve. I don't think any of us that saw this would miss it. But you can imagine sometimes when you're getting a kid that you've got this quick view and you see the disc in the macula, how easy it can be to miss very significant lesions. This is a left eye. You can tell this is a more darkly pigmented child. Look how the tumor looks different based on the pigmentation at the level of the choroid. Tumor vasculature, focal calcification, a little bit of exudative fluid around. This tumor is smack dab in the fovea, so bad position for this. This is the child I showed you with the leukocoria. Large tumor in this eye, microcalcification, exudative detachment, secondary hemorrhage. You're thinking, okay, but look, this is the other eye. I would challenge almost any of us to look at a kid in real life and see this lesion, okay? So one of the take homes that you'll hear me say with management in these children is they have to go to the operating room for an examination under anesthesia. We put an IV in these kids, we mask them, we don't intubate them, we just mask them. And then I'll do photographic imaging, wide field, I'll do ultrasound imaging and fluorescein studies on these kids. And then at the same setting, I'll treat them with laser ablation prior to starting their chemotherapy. So we go from small tumors. The previous classification that we all learned was Rees-Ellsworth. And that classification was about the likelihood of preserving the eye with radiation therapy. So it wasn't a classification, it was a staging. The international classification for retinoblastoma has had some back and forth. I think it's very standardized. For us, it was meant to look at the response to chemotherapy, not radiation therapy. And what was interesting is for those of us that went from the treatment of radiation-related treatment to these tumors to chemo, the response characteristics were different. I'm a really aggressive laserer, so when I treat my kids, they get lasered, but some of my colleagues don't laser, and that led to some very significant local tumor failures with the transition from radiation to chemo, because what was a stable response for radiation was not a stable response for chemotherapy. And then when the tumor gets bigger and bigger, you can have seeding, you can have anterior segment seeding that can look like a pseudohypopion. They can get secondary neovascular glaucoma. These tumors can necrose and have a tumor necrosis factor. Typically when there's inflammation, it's because of an advanced tumor that has active necrosis. And here you can see, if you look here, you don't miss the leukocoria, but do you see all this feathering? So here's the large tumor, and this is all fine microseeding that goes all the way through. Here's this eye here with the tumor mass. You can see the vascularity. You see that when I'm in the OR, we put lid speculums in both eyes. I push like mad with scleral depression to not miss any part of these eyes. So very different appearances. Here's that leukocoria, coloration difference. But one of the things that's a real clinical pearl is virtually never does retinoblastoma associate with a cataract. So if there's a cataract in the eye, think about a uveitis, a post-trauma eye, maybe a congenital cataract, but retinoblastoma typically will have a clear lens as one of our clinical pearls. Here's the tumor, here's the seeding. This is large globular multifocal seeding that you can see here. And you can see there's no clear view because there's microseeding. Here's the tumor just against the optic nerve, but I can see the nerve well. Here's the tumor vasculature. Here's the detachment of exudative retina. And you can see right under the detachment, this little rim of seeding in this eye. And then now we focus more of the tumor. Simply changing the way you illuminate these tumors completely changes the appearance. Here's microseeding, and if you look, here's anterior segment seeding. I don't think we would think of this as a hypopion, but these eyes shift the prognostic risk, so it's important to look for that. Anterior seeding, this you could see more like a pseudo hypopion here, tumor mass in the back of the eye, and then extensive involvement with anterior segment seeding. So I'm going to tell you what's happened over the last 3 decades. So in 1981, before I came to Bascom Palmer, 85% of children with retinoblastoma had the eye enucleated. I came in 1991, and by that point, 85% of the children were being treated with external beam radiation therapy, and only a quarter of the children were being enucleated. When the data came out showing that radiation in children with an RB1 genetic mutation increased the second tumor risk, not the risk of the eye tumor, but risks of other tumors, most commonly osteogenic sarcoma, we moved rapidly away from radiation in those children at highest risk, and we started doing systemic chemotherapy. Brenda Galley in Sick Children's in Toronto was the biggest proponent of this. So look, we go 85% enucleated, 85% radiation, 2001, 85% systemic chemotherapy, and 2021, almost 90% of our children are getting treated at many institutions with focal chemotherapy. So the problem with chemotherapy for retinoblastoma is you use multiple drugs and it destroys the bone marrow's ability to maintain function. So these kids get significantly myelosuppressed. They end up in the hospital, and you're treating them with 6 to 9 cycles of chemotherapy every month. Really high dose treatment. Now, my pediatric oncology colleagues are amazing. They keep these kids alive, but these kids are sick. When we went to focal chemotherapy, these kids don't get sick, because the treatment is going directly to the tumor burdened eye. And one of the unique things about retinoblastoma with the eye is we have an isolated organ system that's accessible. So really huge shifts. So what do you look at? It's always about keeping the kid alive. If you would have talked to me before 2015, I had not lost a single child. From 2015, with 3 kids treated in 2012, I had 3 kids die from metastatic retinoblastoma. So it's devastating. The national survival outcomes for retinoblastoma that is advanced and presents for enucleation in the United States is, I was actually surprised, it's 4%. So the mortality rate for retinoblastoma is 4% for primary enucleation. Our management with chemo, with or without enucleation, and focal therapy, we expect to have mortality rates under 1%. The Shields mortality rate's under 1, Abramson's under 1, mine's under 1, but every kid is 1 kid too many that dies from this disease. We want to keep the eye, but we want it to work. We want to have increased visual outcomes, and a big part for me has been trying to decrease the treatment-related morbidity. So I asked the question early, how can we look at novel treatment strategies? And one of the things we did with this is we treated these kids with systemic chemotherapy, and I'm a proponent of lasering the tumor directly, and many places don't laser. And so the question is, who does better? And that was the first study that we did within the Ocular Oncology service at Bascom Palmer when I had been there for 5 years. And we used a special laser. It is a custom laser that has a very large spot and a very long duration continuous delivery. So we actually built a new type of laser to treat retinoblastoma. These are the 3 most common drugs that are used: Carboplatin is a derivative of cisplatin. This can cause ototoxicity. You can lose hearing. Vincristine can cause cardiac toxicity, and etoposide is what they call leukemogenic, which can cause a secondary leukemia. 6 to 9 cycles, 6 cycles with minimal disease, 9 cycles with advanced disease every 3 to 4 weeks. In my practice, you go to the OR on Friday, I laser your tumor, you get admitted to the hospital, you get chemo on Friday, Saturday, and you go home on Sunday. This was 150 eyes in 119 children, and it looked like this. So what do you see here? You can't even tell where this tumor is. This is the subretinal component. Here we've had the tumor that has mushroomed through the retina, and you're looking and going, I think the optic nerve must be somewhere, but I can't really see it. So this child got 9 cycles of 3 drugs every 3 weeks. One of the things to know is that young children that show presentation with unilateral disease have a significant incidence of second eye involvement. For kids that present with unilateral disease under 1 month of age, 85% of them will have a second eye involved within the first 6 months. So you can't think of it as unilateral disease. And in this child, you'll see there's a laser treatment, 118-month follow-up, so 10 years. And that eye, which you would look and think couldn't see anything, is 20/50. And so that's what the tumor looks like after the first round of chemotherapy. Here's the optic nerve. The tumor has regressed. You can see it's moving away. It's still in the foveal center. You can see the xanthophyll luteal pigment that's present and microcalcification. You can see I've lasered right through the fovea, okay? Progression. And this is the second tumor in this eye. So if I showed you just this picture, you wouldn't even see this. Why is that important? 2 tumors in 1 eye means a genomic alteration with RB1 mutation. 1 tumor in 2 eyes means a genomic mutation. Family history of retinoblastoma and a tumor means genetic defect. And now we can test for these, but even with exhaustive testing, there are some of the RB alterations that you will not find. So negative tests for me are great, but I really counsel the patients and the families that we're going to watch them closely. St. Jude's, which was a very strong institution focused on the oncology delivery with less focus on the ocular component, treated 43 eyes of 25 patients. So they had every single one of their children that wasn't lasered had a tumor recurrence. And in that series of 43 eyes, they ended up enucleating 1/3 of them. Now, I just told you that we didn't enucleate any eyes and the local control rate was 100%. So I argued aggressively that 3-drug chemotherapy was better than 2-drug chemotherapy and that you should not delay focal therapy. Wills did an interesting study that Jerry Shields did with macular retinoblastoma, and he treated with chemotherapy and then treated, but didn't treat the macular component of the tumor, or he treated the macular component and spared the fovea. So what happened? So in the eyes that weren't treated in the macula, he had a 25% failure rate by 1 year and a 35% failure rate by 4. In the eyes where he treated in the macula but didn't treat the fovea, he had a 17% failure rate that was stable through 4 years. They did really well. They only had to enucleate 2 of their eyes. But remember, I just showed you data that said in 119 children that we enucleated 0 eyes and we irradiated 0 eyes. And even though 18% of these kids had another tumor develop, we were able to control all of these eyes with the immediate application of laser plus chemo. So I get stumped sometimes. If I saw this at somebody else's service and it had results better than mine, I'd want to switch, but that's not always true. So this is the large tumor group. Large tumors, which are the ones with vitreous and subretinal seeding, which is the stage 5 RE or the CDE stage. We're able to control about 80% of those eyes, not 100% with systemic chemotherapy, but we're able to control almost 100% now with the intraarterial chemotherapy. So what do we expect? I used to think 100% survival, but losing a child is really humbling. Most of the top centers will report about a 1% mortality rate. Remember, enucleation alone, 4% mortality rate. So enucleation, some people think that just enucleate the eye and you're done. but that really isn't correct. We know that even advanced eyes that are enucleated may benefit from adjunctive chemotherapy, either before or after enucleation. And that's what we do even when we're going to enucleated eye. We'll give 3 to 4 cycles of chemotherapy, enucleate the eye, and finish with 3 to 4 more cycles of chemotherapy. And that's given us the best results. When these eyes fail, they don't fail by the tumor growing. They fail because the seeding in the vitreous and the subretinal seeding progresses. Vitreous seeding here is incredibly complicated because think about it. It's floating in the vitreous. It has no blood supply at all. So chemotherapy that we use typically works by a dissemination of the vasculature, either from delivery into the ophthalmic artery directly or systemically. Seeds don't get a high control rate. So now what we're doing in these cases where the eye is doing beautifully, but there's significant seeding, is we're injecting chemotherapy directly into the eye. That was something that came out of our laboratory in the early 90s. It's kind of interesting to see how the story goes. I presented the data at ARVO, and a very famous ocular oncologist said that if we ever did that to a kid, he'd be happy to represent the lawsuit. He then turned out to be the first person to inject that agent in an eye. It's kind of interesting. So where are we today? I'm going to wrap up now so that we can have some time for questions. We've moved from enucleation, radiation therapy, venous chemotherapy, intraarterial chemotherapy, and intravitreal chemotherapy, trying to maintain wonderful control rates, keeping these kids alive, keeping their eyes and having function. It's been a huge journey, and it's been a journey that doesn't come with the standard evaluation of any other therapy. I was one of the few people that had a retinoblastoma laboratory for those 2 decades. We really are altering therapies in the children that we're treating, and that requires some really good understanding and good discussion with the families that participate. So this is how I'm going to end. This is the first child that was treated with primary therapy with intraarterial chemotherapy. Look, she's 7, so you're like, that's weird. So she was not referred for retinoblastoma. They thought that she had a granuloma and referred her. And then when we looked, her vision was excellent. Her pressures were good. My fellow looked, and this is the view my fellow got. And she looked and said, I don't know why he's here. But if you were to look, one of the things I tell my fellows is if there's an abnormal blood vessel, follow it to the periphery and see what's there. And if you can see, you follow this out, this is an abnormal vessel at the nerve, and here's the retinoblastoma lesion. It's got an endo and exophytic component. It has an exudative detachment. And what you can't see is way up here, just posterior to the aura, is a second tumor. So uniquely, this kid has an RB1 mutation, 2 tumors in one eye presenting at age 7. Here's the ultrasound. You can see the calcification. Here's the unusual shape of the tumor. Treatment algorithms that we've discussed. In the old days, enucleation. In the younger days, radiotherapy. In the more recent days, systemic chemotherapy. And then we'll talk about this focal chemotherapy. And that's kind of the novel ways to do this. One of the things that you can do with the eye is you can inject chemotherapy around the eye. This is the first child ever treated with an injection of chemotherapy along the wall of the eye itself, not into the eye. You can see here's the chemotherapy, here's the tumor, and there's the regression pattern of the tumor itself. So that was the first patient treated in 2010 with an injection. This is the intraarterial chemotherapy. It was developed in Japan. This is what it looks like when you inject into the ophthalmic artery. So here's the ophthalmic artery, and then you can see here's the anterior ciliary processes. Here's the shade of the globe. The Japanese did this by passing a catheter up and blocking the carotid just distal to the ophthalmic artery. So there was no blood supply to the brain while they did this. I had no interest in doing that. I thought that was potentially catastrophic. But Pierre Coban, who was at Sloan Kettering, said, I can put a catheter in the ophthalmic artery. Now remember, these are kids at 3 months of age. The ophthalmic artery is less than the size of a piece of spaghetti. And yet he felt he could put a catheter in there, and that's what we do routinely. This is the hemisphere injection that we do. This is early. You can see the perfusion going into the eye, advancing. Here's the wall of the eye itself. You can see the eye beautifully. They're beautiful studies, but this drug is preferentially going into the eye itself. There's very little lateral spillover. And this was the first 12 cases that I did. These were all patients scheduled for enucleation. And we talked to the families and said, we're going to take your child's eye out. Are you comfortable to let us do this? And shockingly, they were. What happened, which was unbelievable, is that 9 of the 12 eyes that were scheduled for enucleation were not enucleated. So 75% of the eyes planned to be enucleated were saved with that technique. This was the first complication, which is this transient hyperemia of the forehead due to one of the branches off of the ophthalmic artery. But here's our kid. So, none of my stuff's playing. So here we are. This is a Purchase-like retinopathy. The tumor already is smaller. The detachment's resolved. That's in 2009. I'm lasering. Tumor's getting smaller. Lasering again, tumors getting smaller, scarring. Here's what it looked like in 2009. This is what it looked like in 2014. This eye is 2020. Never received systemic chemotherapy. So we've seen a major shift in retinoblastoma. The first thing to understand with retinoblastoma is make the correct diagnosis. Don't miss this ever if possible. Refer aggressively and understand that there are incredible options for treatment. Enucleation is still used. We don't use radiation therapy, but some centers do. I do use systemic chemotherapy. I do use intraarterial chemotherapy, and I do use the direct periocular and intravitreal chemotherapy. And with that, I'd like to say thank you guys all for letting me lecture. I think I have hit my time limit.
Pretty darn close. There is one more question that came in.
I'll take it.
Can you, maybe 2 now. Can you comment on the advantages, disadvantage between arterial versus venous chemotherapy, and does it matter?
Right. So the intraarterial ophthalmic artery chemotherapy is cannulation of the ophthalmic artery and direct delivery of the chemo. The advantage to that is you don't get any systemic delivery. So there's no secondary risk of myelosuppression. These kids don't get sick. What's the disadvantage? The disadvantage is that treatment may alter the choroidal vasculature. And if you looked at the picture that I showed you, there was pigmentary changes. Even though the vision was 20/20, there's been changes into the vasculature. We see that now in about 20% of the eyes that we treat. So very specific delivery, much lower systemic morbidity, and intraarterial chemotherapy seems to have a higher local success rate. Does have potentials for local toxicity, but those look to be relatively small. Great question.
Another question, how can you tell a difference using retroillumination or direct ophthalmoscopy between a large central cataract and leukocoria in kids?
So, nobody, I hate to say it, but hardly anybody transilluminates anymore. Where transillumination to me is really helpful is in pigmented tumors. You can transilluminate them at the bedside or in your chair, and they will delineate the tumor beautifully. In fact, for the cases that we did today, the way we mark the melanomas is using transillumination. So I think that transillumination can be helpful, but really the single most important test with congenital cataract is if there's a view to do indirect ophthalmoscopy and ultrasound. So those are my 2 keys. Transillumination I do, but I don't find it really that helpful any longer.
I think that was the last question, Tim. If you don't mind unsharing your screen, I'll take over.
You got it.
And just to let you know, in our chat room right now, you're getting your virtual round of applause from the audience.
Thank you. Thanks, guys. I love when Joe does this, and it's really a pleasure to speak to you. And you remember, you guys are on the front line, so this is really, really, really important. I love what I do, but I can't do what I do well without you guys being right there with me.
Well, we really appreciate it, Tim. It was a fantastic lecture. It's really something special to hear somebody talk about an unusual or a challenging set of conditions that they do every day and talking about their own research. And it's very refreshing to hear you say how much you like getting the referrals. And I'm only going to talk about what I see and not what was seen and what needs to be done, because I'm sure virtually everybody on this webinar tonight at one point or another was chastised by some specialist for quote unquote wasting their time. So your attitude is just so refreshing. We really do thank you very much.